Hi, I'm Briana, and along with Maritza, we are going to be presenting on spina bifida. So our agenda for today is to introduce spina bifida, go over the role of occupational therapy within this population, and then introduce our intervention session along with our fictional client, the goals we have for him, and our clinical reasoning. So spina bifida, it's a type of neural defect, is a congenital defect of the central nervous system resulting from an incomplete closure of the embryonic neural tube during the first 4 weeks of gestation. There are three types that we will go into more on the next slide. Spina bifida occulta is a closed lesion, and spina bifida aperta is a cystic protrusion through the lesion in the spine that is visible on the back. And there are two types of that, meningeocele and myelomeningocele, or MMC. The etiology is widely unknown, but the most agreed upon etiology is a maternal folate deficiency during pregnancy. It occurs in about 1 in every 2,758 live births within the United States, and surgical intervention is always required for spina bifida aperta individuals in utero or within 72 hours of birth. So these are the three types of spina bifida. Like I said, occulta is a closed lesion. There is generally no neurological involvement. There is no lesion on the back. And so there is usually minimal to no functional deficits. Meningeocele is a less severe form of SBA. And there is a protrusion on the back, but there is no neural tissue involvement. So this rarely leads to any sort of long-term disability. MMC, however, is the most severe and common form of spina bifida. There is also a visual protrusion on the outside of the affected vertebral level. However, along with the CFS or CSF and meninges, there is a portion of the spinal cord and associated nerves involved. So this exposes them to amniotic fluid in the environment and compromises healthy CNS development. So what does this look like? It will vary in severity based on the location of the lesion, the degree of damaged neural tissue, and the timing of surgical intervention. It will lead to weakness and paralysis of the lower extremities, along with decreased sensation. Depending on the level of the lesion, it could lead to neurogenic bowel and bladder dysfunction and seizures. It can also lead to congenital and/or acquired orthopedic conditions. Hydrocephalus and Chiari-2 malformations are almost always present with individuals with MMC, and those can lead to deficits in fine motor skills, praxis, balance, VMI, and coordination, along with weakness in the upper extremities, ocular motor difficulties, and dysphagia. It almost always leads to delayed and disrupted motor development, decreased strength and tone in the trunk, and varying levels of psychological and psychosocial impairments.
Now moving on to the role of occupational therapy within spina bifida, our main focus is functional mobility and increased engagement within independence. We also want to focus on assisting and learning within the occupations of dressing, self-care and bathing, bladder and bowel management, use and care of orthesis. Positioning for play and activity participation is highly important to address within OT. We would want to assess and treat deficits in sensory processing, VMI, praxis, fine motor skills, balance and coordination, and trunk stability. Social skills, school and play participation is highly important as clients within spina bifida are highly impacted within these skills. Education in the use of compensatory strategies and adaptive equipment is highly important to use in order to transfer skills into various environments while they learn those skills within OT. Family and caregiver education and training, again, is important to transfer skills. Working within a multidisciplinary team and providing referrals and a home program provides clients with spina bifida a holistic form of care. Now moving on to our fictional client, Rebel is a 5-year-old boy who was diagnosed at 20 weeks gestation with MMC at the level L2. He was also diagnosed with hydrocephalus and Chiari-2 malformation. Here's more background within his living situation. As for OT, we would want to evaluate him in an outpatient pediatric clinic. Rebel really enjoys fire trucks, jigsaw puzzles, action figures, and arts and crafts. He uses a posterior walker and hip, knee, ankle, foot orthoses for mobility within his school and home environment. And he uses a wheelchair for community mobility or for longer distances. His present level of performance, he has decreased VMI skills, fine motor, gross motor, praxis, and upper extremity strength, including bilateral coordination and endurance. He has paralysis in both his lower extremities. He is decreased within his core strength and postural stability, which is then affecting his functional mobility and participation in self-feeding, play, and school activities. He's Mod A in most ADLs. He has difficulty with social participation and social play skills due to his low self-esteem and self-efficacy. He requires maximum verbal cueing for participation in social play. Rebel and his mom would like for him to work on becoming more independent within his ADLs and increase his play skills, social participation within his peers. As for goals for Rebel, within the long-term goal 1, we are addressing constructive play, and we are addressing short-term goal 1 within the intervention, which is client will create two-step art project of choice with 50% precision with min A and the use of 2 adaptive strategies and no more than 3 verbal cues in 3 out of 5 opportunities within 3 OT sessions. For long-term goal 2, we are addressing social play, and within the short-term goal 1 in the video, we are addressing client will initiate and continue play for 5 minutes with 1 peer during recess with supervision and no more than 3 verbal cues in 2 out of 5 opportunities within 3 OT sessions. For long-term goal 3, we are addressing lower body dressing. And for short-term goal 1, client will complete donning and doffing socks with min A and with the use of 2 adaptive strategies and no more than 3 verbal cues in 2 out of 5 opportunities within 3 OT sessions. Now for our clinical reasoning within those goals, we first want to have Rebel do a preparatory activity, which this consists of utilizing MCML within the scooter board to help him learn new motor tasks to increase his skills and self-efficacy. This activity also builds a need for participation in occupations that addressed in our intervention that focus on head and neck strength, trunk stability, bilateral coordination, ideation, praxis, and VMI. As for the constructive play intervention, again, we are utilizing MCML within this activity, which builds motor development to increase constructional play within his participation. It encourages bilateral coordination, fine motor skills, praxis, ideation, VMI, postural stability, and self-efficacy in play.
So for our social play intervention, we're going to focus on building his self-esteem and self-efficacy in social play by using an age-appropriate cognitive strategy of social stories. This is going to encourage Rebel's ideation and address his psychosocial difficulties. And we're also going to teach him an age-appropriate breathing coping strategy by using a little catchy song. For our lower body dressing intervention, we're going to start that off by doing a prep activity of toe painting, which is going to address sensory stimulation and provide awareness to his feet before the activity. And then we are also going to provide him adaptive seating and socks to help compensate for his weakness and his motor and sensory deficits in his lower extremities, along with his postural instability and upper extremity deficits, and promote strengthening and independence in lower body dressing. And we are going to provide appropriate physical and verbal assistance for his safety. And finally, we're going to end with an education portion that's going to concentrate on implementing our home program and address mom and Rebel psychosocial needs. And this is our intervention demonstration video, which we provide the link for. And here are our references. Thanks.
You.
How do I stop?